For non-small cell lung cancer, the diagnostic workup really is well described here. One would, of course, want to get an X-ray of the chest, but clearly a full metastatic workup is important. One can do that with CT scan or PET scan. And then, of course, it's always important to know if there is CNS involvement or not. In many cases, that might necessitate treatment with radiation first. Mutational testing and profiling, critical these days. So at our center, Yale Cancer Center, everyone with new lung cancer that comes in, we're sending their tumor for profiling, which includes the EGFR, ALK, and ROS1 mutations. And also, we test those patients for PD-L1. So that all is critical. And then, of course, there's the no substitute for seeing the patient and evaluating them in person and their performance status, perhaps on multiple occasions, which has been done for this man as well. In 2017, most patients will have molecular testing on their tumor. In fact, I believe it should be a standard of care for all non-small cell lung cancer cases. That would include EGFR, ALK, ROS1, and I believe PD-L1. This all really should be done in fewer than 10 days. Those would be the CAP, the College of American Pathologists guidelines. We try to do that. I think it's important because you don't want to start your frontline therapy until you've ruled these things in or out, because it does affect whether you would give the patient immunotherapy, whether they would get an oral targeted agent or standard chemotherapy. I see this happening more and more across the United States. Uptake has been high, but it's taken some time. And I worry that it's not available in all areas, and certainly not around the world. But in the United States, this is what I would consider the new standard of care, and there are more and more places where this can be sent out to be done. Molecular testing is critical for the use of EGFR upfront therapy. You wouldn't use it unless someone had a mutation. The two most common mutations, and the ones that have been shown to respond typically to the oral EGFR agents, are either exon 19, which tends to be a deletion, or exon 21, which tends to be a point mutation. Both are what we would consider the canonical EGFR mutations with 60 to 70% response rates to the erlotinib, gefitinib, or afatinib, the three approved agents in the United States. If one were to have a mutation in a different area, it still could respond, but the chances are much less. And so we would call that an atypical, non-canonical mutation. One thing that has been shown in a number of studies is the results are a little bit better for the exon 19 versus the deletion versus the point mutation in 21. It's a more significant mutation. But all these mutations are ones that one would want to treat right away with an oral EGFR therapy.